It looks fine.
Perfect.
All right.
Good.
So, good morning, everybody. Welcome virtually and in person to Grand Rounds. And in the custom that we've been used to, I'd like to acknowledge that we're gathered on the traditional and ancestral and unceded territory of the Coast Salish peoples. And we're grateful for their stewardship of these lands. This morning's Grand Rounds is an intersection between nephrology and geriatrics. Dr. Wayne Hung, who's trained at UBC in both nephrology and geriatrics, is going to be presenting the round. Dr. Hung.
Thank you, Dr. Katzen, for the introduction. I'm really pleased to be here today to tell you about a topic obviously very near and dear to my core interests, and hopefully over the lunch hour, I can give you a bit of a bird's eye view on this area of geriatric nephrology. So I don't have any disclosures. I unfortunately can't join you in person today, so I can't see who's there in the audience, but I thought it might be nice to have a more interactive session. So I don't know how many of you have used Whole EV before, but I think it'll be a nice way for us to interact anonymously and maybe in a bit of a fun way. So if everyone can pull out your phones and go to this website, pullev.com, and then enter my username there, Wayne Hung 710. I just want to test this out. And I thought maybe what we can do is answer this question. Can everyone see my screen? I hope you can. But if you go on pullev.com/WayneHung710, you should see a free text box there for you to enter your response. So if you're on CTU, if you can put that in, geriatric medicine, perfect. Nephrology, great. So if you have two words, just enter them in as one word. For example, if you're on infectious disease, you can just put that all as one word.
Hello.
Just to remind everyone to mute their microphones if they can, please. Perfect. Any other responses? Sort of the general idea. Perfect. Okay, so I'll go back to my presentation. So a lot of geriatrics and nephrology, perfect. I'll go back to my presentation here. Okay, so to start off, as you all know, we are now seeing more and more older adults globally, and it's projected that come the year 2050, in about 25 years or so, the number of people over the age of 65 is going to triple from 700 million currently to even 2 billion at that time. Certainly, we see that reflected in the CKD population as well. So the the graph on the right is from the Canadian Organ Replacement Registry. This is a little bit older, from 2017, but looks at the previous 20 years or so. And you can see there in that top solid line, that represents the group of patients over the age of 75 in terms of incidence of ESRD. So you can see that line really jumped in the late 90s to early 2000s and has really stayed as the highest group out of all the different age groups. Some theorize that we saw this big jump around that time for a number of reasons, maybe because we were now seeing the end results of better overall chronic disease management like diabetes, hypertension, and so patients are surviving onto ESRD more so than before. Certainly, when I pulled more recent data, so this is from this year's summary, you can see that this group of older adults remains the most predominant age group in terms of incident ESRD patients. I wanted to highlight the prevalence as well in terms of ESRD patients by age group, and specifically to compare on the left the pediatric population versus on the right the older population over age of 75. And you can see there in the rate per million population, that number in the pediatric group has kind of been stable and probably slowly declining, versus on the right in the older adult population, you see that the prevalence is sort of climbing year on year. So that brings me to my first question for you guys. What are some of the considerations that come to mind for you for older adults as they develop a near end-stage kidney disease? Pop back to the poll and move on to the second question. So again, if you have 2-word responses, just leave them as 1 word without the space. I'd be interested to see what kind of things you come up with here. Frailty, certainly. Goals of care, absolutely. Symptom management, for sure. Culture. Quality of life, geriatric syndromes, reviewing medications, living well, education. Let's see what else has popped up there. Oh, it's flipping on me a little bit. Nephrosclerosis, yeah. And I think some are probably repeat entries as well. Community, I see. Quality of life, again, dialysis options. Perfect. Well, you guys are ahead of me. Hopefully I can cover some of those topics. Yeah, thank you for that. Thank you for all those responses. So I'll go back and keep all those things in mind. So in ESRD, I wanted to go over the broad categories in terms of options, just so we have some framework for the next hour or so. So when we think about our options at end stage, we think about these 4 broad categories. So really there are 3 renal replacement therapy categories, including home therapies like peritoneal dialysis or home hemodialysis, in-center hemodialysis, which is I think what most of you are familiar with, transplantation, and then the 4th path being the conservative care approach, which is a non-dialysis symptom-guided way to treat end-stage kidney disease. And so to briefly go over each option, as you all know, transplantation remains from a survival, quality of life, and health economics standpoint, the preferred option. But obviously, not everyone is a candidate for transplant, nor would the benefits necessarily be there for them. And it's really no small feat. There's extensive workup that's required. Obviously, you've got to be a candidate. There's extensive follow-up as well, and you can't discount the lifelong immunosuppression that is required and all the different complications and risks associated with that. But on the upshot, you get to really, quote unquote, normalize your life. With home therapies, whether it's peritoneal dialysis or with home hemodialysis, you do have a form of dialysis that you have to stay on, but in its own way, it is patient managed, patient driven. There's flexibility in terms of when and what you do it, more so with home hemodialysis versus a continuous therapy like peritoneal dialysis. But for an able-bodied person, you can travel, you can work, and your diet isn't as restrictive because you're doing dialysis more frequently and perhaps at a higher dose than an in-center patient. So in-center hemodialysis, again, the population that I think most of you are more familiar with are these patients who, don't have a transplant or are potentially waiting for a transplant, and for whatever reason aren't doing home therapy, whether because they wish not to do it or perhaps because they cannot do it. And so are dependent on a hospital facility or a community dialysis unit to provide that hemodialysis, meaning that the scheduling is more restricted, unfortunately, and therefore you have strict dietary and fluid recommendations. And of course, if you're a younger person who is still working, that would be quite limited. Or if you wanted to travel, again, that would be limited by, the dialysis capability at your destination. And so finally, when we talk about the conservative care pathway, it really is a palliative approach to end-stage kidney disease, where the focus is really on symptom management, as many of you have alluded to, goals of care, advanced care planning, and during this process, our kidney care clinic stays involved, plus or minus involvement of a conservative care nurse, depending on where you are. The goals are really to plan for the end of your life and to be comfortable. So my next question for you then is, okay, knowing some of these renal replacement therapy options, what are some of the benefits that come to your mind for older adults in doing dialysis? Longevity. Functional improvement. I think that was maybe one response. Any other thoughts? Symptom management, okay. Symptom management, autonomy, okay. All right. Thank you for that as well. So I want you to keep those things in mind as I move on in my talk again. So there was a survey done, this is now many years ago, in terms of what the perception of dialysis was to older patients. And at that time, this is in the 90s, the vast majority of elderly patients indicated that they would choose dialysis. Even those in nursing homes would want dialysis, and most of these patients would prefer for it to be done at home. Interestingly, they reflected that the reasons for wanting to do dialysis was that it would help them be independent, to be free from major symptoms, and to have good quality of life. So my next question then is, what do you think the 5-year survival rate is for older patients on dialysis, the age over 75? And I ask because I think one or some of you pointed out that longevity might be one of the benefits of doing dialysis. This one's multiple choice, maybe a little bit easier. Got some results coming in. Oops. Let's see. Okay. So option B seems to be, oh, it's sort of evened out now between B and C, 40 and 25%. Okay. Nobody thinks it's 65%, and a minority of people think it's about 10% at 5 years' time. Okay, now I think 40% is winning out. Okay, well, let me show you the data. This is our most recent up-to-date Canadian data looking at survival rates for dialysis patients separated by age groups, going up to 10 years. And so I've highlighted for you that solid line there with the crosshatches. That is the group we're talking about. So at 5 years' time, the survival rate is about a quarter, right? So for reference, that's comparable to many advanced malignancies. So for those of you who chose option C, that is the correct answer there. So when we think about survival on dialysis, we know in general that life expectancy is reduced compared to age-matched controls who are not on dialysis. And so for patients over the age of 65, some studies suggest that median survival is about 4 years. And again, as you've seen on the previous slide, a 5-year survival rate about 25% in the Canadian context. These numbers on the screen there are American, which are a little bit worse. And unfortunately, really haven't seen an improvement in that survival data over the past few decades. And when studies have compared hemo to peritoneal dialysis patients, there really hasn't been a demonstrable significant benefit in patients who are doing peritoneal dialysis either. In the elderly patient population specifically, some studies, when they have adjusted for things such as comorbidity or competing comorbidities or high degrees of frailty, have found that that survival benefit shrinks even further, with some studies suggesting benefits in the order of months in this patient population, of which you can imagine a lot of that time is spent in hospital dialyzing or admitted or at the end of life. So the benefits of dialysis in terms of survival in this patient group is there, but how meaningful it is, I think is up for debate. What about some of the trade-offs in terms of doing dialysis for older adults? What are some of the things that come to mind for you guys? Time cost, time consuming, yeah, so time, once again, frailty, fatigue, hope, complications, discomfort, quality of life, once again. Excellent. So many of the same themes that you guys identified very early on in terms of the considerations you have for older adults going on to dialysis in the first place. Thank you very much. Okay, let me tell you a little bit more about this. So quality of life. So there were some much older studies that have looked at quality of life for dialysis patients in the elderly. And interestingly, these studies in the 80s suggested that quality of life was actually acceptable. And the reason was that many of these patients saw dialysis as a way to socialize. But I think the patient population on dialysis, especially in the elderly, is probably different than the ones that we do see today. And so most recent studies would reflect that. So in about 40% of patients at dialysis initiation, they reported having impaired quality of life, with that increasing to about 80% of patients a couple years into dialysis with a significant burden of symptoms. And so I wanted to show you some data relating to the burden of symptoms in end-stage kidney disease, whether or not you are a patient on dialysis, or if you're a patient with ESRD not being treated with dialysis, i.e. on the conservative care pathway. And you can see that, regardless, there is a high prevalence of symptoms in many, many different domains. Any of them could be quite distressing and bothersome for the patients. Frailty, as many of you have pointed out, is a very important topic and consideration in ESRD and in elderly patients. When you think about it, having both ESRD and an increased age really puts you in a classically frail population. They often have many multiple competing comorbidities, often risk factors that have driven them into ESRD, like diabetes and other complications, hypertension, other cardiovascular comorbidities. They are often on many, many medications, again, to treat their underlying diseases, to treat the complications of ESRD and or any symptom. They often have profound sarcopenia and are a high falls risk with the complications of falls, such as fractures. And again, as you have seen, a heavy burden of symptoms that can impact quality of life and resulting in high levels of physical disability. When studies have looked at dialysis patients and looking at how many of them meet criteria for frailty, they found that upwards of 2/3 of all dialysis patients would meet the criteria for frailty, and even upwards of half of younger dialysis patients would be categorized as frail. We know that frail patients are actually more likely to start dialysis at higher GFRs, which suggests that the uremic symptoms that often prompt us to start patients on dialysis may overlap with some of the frailty-related symptoms, and may in fact explain why some studies that have compared dialysis starts at different GFRs found that if you started at a higher GFR, there actually may be some higher mortality, but perhaps what you were seeing there were patients who maybe had more frailty, and therefore their mortality outcome was worse. And as you all know, frailty in itself is predictive of mortality and hospitalization, and the same is certainly very true in ESRD patients who are frail. This is a neat study that actually looked at clinical frailty scores and survival after starting dialysis. And you can see that kind of is a linear relationship in terms of your clinical frailty score at the time of dialysis initiation and your predicted risk of mortality. And so I think this study was over a period of 1.5 years or so. And you can see if you had a clinical frailty score, I'm just going to move my box there, of about 7, at the time of dialysis initiation, only half of the patients are alive at 1.5 years' time. From a morbidity standpoint, frailty is certainly associated with issues with vascular access, worsening quality of life, increased hospitalizations, higher levels of anxiety, depression, intrusiveness of the illnesses. And not surprisingly, patients who are frail at the time of dialysis initiation tend to have lower cognitive function and tend to have further a decline in their cognitive impairment after dialysis initiation compared to patients who are not frail to start. So from a functional standpoint, many of you have pointed out that it is an important consideration for older adults and certainly a potential trade-off in starting dialysis. And so here is the data to support that thought. Here, there are a lot of colors here, but really what you're looking at is the dark blue color, which represents independent older adults at the time of dialysis initiation. And so in this study, they were specifically looking at more independent older adults. And so the majority of these patients, 78% of them, were in this group. But you can see at 0.5 years, so 6 months, that had shrunken down to 28%, and then continued to decline as time goes on, with a large proportion of patients having either died or decreased in their functional status such that they were now requiring assisted or supported, i.e. sort of dependent living circumstances. And of course, there are a lot of coexisting geriatric giants with these frail dialysis patients as well. Falls being something that is increased in dialysis. And of course, the complications of the falls as well, fractures increasing across the spectrum of kidney disease, and again, resulting in increased mortality. Elderly patients are already prone to developing malnutrition, weight loss, and certainly in CKD and with ESRD, you have additional contributors such as uremia, you've got nutritional losses during dialysis, higher rates of depression, and a very restricted diet, which overall, again, contributes to this problem and further increases the morbidity and mortality. Medications are also something to really pay attention to in this group of patients. As many of you have pointed out, drug therapy is already challenging with elderly patients. But when you add to that CKD, we actually see an increase in the number of drug-related adverse events. So polypharmacy, a very big problem as well. So cognitive impairment, very prevalent in chronic kidney disease and probably under-recognized. On the right there is a graph from a study which looked at MMSE scores staged by eGFR, and interestingly, there was a bit of a graded relationship between how severe your chronic kidney disease was and your level of cognition. So there, the exact prevalence of cognitive impairment is variable in the literature, but I think quite significant. So some studies have suggested upwards of 70% of hemodialysis patients having undiagnosed cognitive impairment. Some other studies suggest, numbers more in the realm of maybe 40% for mild cognitive impairment, 20% or so for dementia, but quite sizable numbers. We know that cognition declines faster in patients who are on dialysis compared to the general population, as well as non-dialysis CKD patients. And the thought is that a lot of it is driven by cerebral hypoperfusion that happens when you're on hemodialysis specifically, which they've seen on functional vascular brain imaging studies. Dementia, not surprisingly, is associated with worse survival and more withdrawals from dialysis. And as I mentioned earlier, patients with dementia have worse outcomes from a mortality standpoint. So on the right there on the graph, you can see at 2 years' time, only about 50% of patients with dementia on dialysis are still alive. End-of-life care in ESRD often involves quite a lot of acute care as well. So when they've compared patients on dialysis at the final month of their life compared to other advanced conditions such as cancer or heart failure, they found that at the end of their life, dialysis patients were much more likely to be admitted to a hospital, to be in the intensive care unit, to undergo invasive procedures, to die in hospital, and much less likely to use or be in hospice setting. Dialysis regret certainly is a real phenomenon, with some survey data suggesting anywhere between 20 to 60% of patients having some form of dialysis regret. And when they have looked at the predictors for dialysis regret in these patients, the biggest reason seemed to be having chosen to do dialysis in order to please other people, such as their doctors or their family members. And they were less likely to have regret if they had some prior discussions with their providers about expected survival, life expectancy, and had some form of advanced care planning that was completed. So this brings me back to the conservative care pathway as a option for older patients in ESRD. As I mentioned, the kidney care clinic remains involved in their care, but the focus of the management changes towards more symptom control, towards provision and connecting patients with appropriate palliative services, and to make sure that we have good, thorough conversations with regards to their medical wishes and goals of care. All of these things that you guys have really appropriately identified in your responses so far. So the next question for you to think about is, what is the median survival for ESRD patients who are managed with conservative care? What do you think it is? I'm just going to move this box down. Is it hours to days, days to weeks, weeks to months, months to years? Okay, got a good number of responses. Oops. Oh, there we go. So the leading answer seems to be months to years. People thinking weeks to months. Great. Well, let me show you the data there. So this is actually a fairly recent systematic review published in JAMA, looking at the median survival for ESRD patients managed with a conservative approach. And, you know, it's quite heterogeneous, as you can see, but it really ranges anywhere from, you know, I think 1 month in one study to 40 plus months in another study, but really, you know, hovering in that range between sort of 20 months and 30 months or so. So I think, yes, you guys are correct. It's really in the order of months to years. These are older studies, but, you know, in the past, again, they suggested that the survival could be years, with the median survival being somewhere in the realm of 14 months. So again, months to years. And when compared to hemodialysis patients, conservatively managed patients are no more likely to end up in hospital, but they are certainly more likely to die at home or in a hospice setting. So hopefully you can see why older patients with ESRD who have, you know, a lot of the competing geriatric syndromes, frailty, it really ends up in this big sort of interacting web of issues to consider, and it can really get quite difficult to manage. So I think this is where geriatric medicine really comes in. You know, they really are the experts in dealing with frailty, complexity, multimorbidity, looking at what matters most to patients, looking at mind and mentation and mobility and medications, whether or not, you know, the aging process and pharmacokinetics should be considered. I think a geriatrician's superpower really lies in this comprehensive geriatric assessment, which, you know, to me is a really, really invaluable tool, and comprises of, you know, a diagnostic process, a prognostic process, and certainly, you know, offers an integrated short-term and long-term plan for many, many, many of these issues. We know that CGAs have really well-studied benefits in, you know, quality of life, in improving cognition, in functional maintenance, and delaying institutionalization. Unfortunately, I think we traditionally have had some challenges in how we can provide these geriatric assessments for nephrology patients. Obviously, in a typical dialysis or renal setting, it can be really challenging to do these thorough assessments. Certainly, you do require sufficient time for a comprehensive review as well. Again, as you've seen, the issues are often really intertwined and very complex, and often you're not dealing purely with a renal problem or a geriatric problem, and really it's a combination of both. So it may be difficult for individual consultants to manage independently. And then depending on where an ESRD patient is, access may be challenging if there aren't any geriatricians geographically, or they may be some under recognition in terms of the benefit of seeing a geriatrician by their nephrology providers. So this is one of the first studies that sort of captured how you could incorporate geriatric assessments into a nephrology clinic. This is published in JAGS in 2016 in the States, and it describes two different programs. So one that they call CGA for CKD was a partnership between the two specialties, where a geriatrician was embedded into the kidney clinic, and then there was then co-management of patients and development of plans in tandem with regards to their kidney disease. The other program was something they called the Renal Silver program, and in this program they had a nephrologist with geriatrics training, and also included him in the renal palliative clinic to again use a geriatric lens to inform CKD treatment plans. And then if there were any identified geriatric issues that needed downstream management, then they would refer onto the local geriatricians. In either program, they were able to see that there was a significant proportion of patients identified to have functional limitations and cognitive impairment, which was not otherwise identified in other assessments. They were then able to consider these factors in individualizing a treatment plan for their chronic kidney disease. And overall, they thought that this supported a practical application of having geriatric assessments in guiding some of the CKD care and decision making. And they summarized that they found three notable themes in terms of how geriatric assessments can help in this patient population. So number one was helping the providers anticipate risks and then prioritize concerns for the patient. So for example, if you were able to identify cognitive impairment, then that certainly has an impact in terms of how this patient would self-manage the chronic kidney disease, or how they would manage therapy for dialysis. Secondly, these assessments were helpful for patients and their providers in recognizing and discussing these preference-sensitive treatment decisions. So many of the participants or patients in these studies, after having conversations around functional status, cognitive impairment, were more likely to opt for a conservative approach to the ESRD after understanding, what the impact of dialysis might be on their quality of life. And then thirdly, they were able to identify the other group of older adults who are actually robust and resilient, and who may really benefit from a more traditional model of CKD care that really requires a longer time horizon to benefit. And so over the years, I think there's really been a lot of increasing interest in the area of geriatric nephrology. So For example, on the American Society of Nephrology, there's now an online curriculum where anybody can kind of look through the documents and learn and familiarize themselves with some of the domains. And we certainly have seen a lot of programs pop up in the States looking at combined geriatric plus minus palliative nephrology training, sort of in many different schools and parts of the country. And so in Canada, where do we stand? So for a long, long time, the only place that had geriatric nephrology was in Toronto, with Dr. Vanita Jassal, who trained in the UK and is double boarded in both. And so she has a bit of a unique setup in Toronto where she runs an inpatient geriatric nephrology service that runs parallel to the general consult team, where she would then see, elderly ESRD patients that have more geriatric issues. She also runs a hemodialysis unit at a rehab center, which is also quite interesting in that she then is able to tailor how the dialysis is provided to really prioritize and facilitate rehab for patients. She doesn't quite have a dedicated geriatric nephrology clinic. Really it's just Dr. Jassel's, the expert, people refer to her type of thing. And she does have a fellowship program that she offers where many people have sort of gone through and done extra training with her. So over the past year, McMaster has since developed their own program. And this one, I've had the privilege of being at both places. And I found this to be an interesting model because this is a more collaborative clinic between a geriatrician and a nephrologist. So Dr. Mona Sidhu is a geriatrician who actually trained in Toronto with Dr. Jassal doing the fellowship. And then Dr. Joseph is a nephrologist who has since then trained with Dr. Sidhu. But they started a clinic a year ago in Hamilton, soliciting referrals internally from nephrologists from both their kidney care, their hemodialysis, their peritoneal dialysis, and their transplant services to assist with geriatric syndromes. And I think they were very happy with the results, and this clinic has since been formalized. They're also building their own version of a fellowship program and have now been included into the curriculum for their core nephrology and geriatric trainees. And I believe they're now accepting palliative care trainees and other advanced nephrology trainees as well. So it's pretty exciting for them. So with that, we wanted to think about how we can come up with our own version here at St. Paul's. And so I've been very fortunate to have had the support of the divisions here. And we thought that it might be a really good opportunity to give me that enhanced geriatric training and to really see the intersection between geriatrics and nephrology in an outpatient setting. So we started this clinic in January of this year with supervision from the attending geriatricians, Dr. Chase, Dr. Cook, and Dr. Hill, with the goal to provide dedicated CGAs for patients with kidney disease, focusing on domains affecting their nephrology care. And just like with Hamilton, we wanted to open up the service to any renal patient, whether you are on hemodialysis, peritoneal dialysis, whether you had CKD being managed in the kidney care clinic, or if you were pre-transplant or post-transplant. So for the sake of time, I'll just show you some of the more basic data, but overall we've had 21 clinics to date. Typically we see about 2 new consultations each clinic. So overall we've had about 40 visits or so, with a number of them being follow-ups. And most of our patients have come from hemodialysis or transplant, mostly pre-transplant, with a few from kidney care clinic. Again, for the sake of time, I'll kind of just let you look at some of the characteristics of these patients, but overall, I think they're very apt group of patients. They're typically a bit older, with some degree of cognitive impairment, as you can see there on their MOCA scores, who are for the most part, mildly frail, with some borderline gait speeds and some degree of comorbidities. In the hemodialysis group of patients, we saw that the most common reason for referral was for cognition, in addition to other things like frailty review, function, falling, behaviors on dialysis, so on and so forth. And for, I believe, most patients, we were able to make a diagnosis of dementia, mild cognitive impairment, in addition to other issues that were identified. And interestingly, we were able to find a few patients who did not have dementia as well. And I think that is really helpful prognostic information. And from those consultations, we were able to take a number of actions, often communicating or liaising back with the renal team, involving allied health, home health, revising goals of care, revising medications, and maybe sending workup for some reversible causes of cognitive impairment. For the transplant patients, it was a little bit of a different flavor, because often these referrals would be made from the pre-transplant clinic for patients who are being assessed, but who the transplant nephrologist might feel are a bit borderline and may have concerns. So often we were doing a CGA with an additional sort of perioperative risk assessment as well. So it's only been 10 months or so. So of the 8 pre-transplant patients, 5 of them had been approved. The other 3 are still waiting for a decision. And of the 5 who have been approved, 3 have been successfully transplanted. So that's quite encouraging to see. And with these assessments, we were actually able to give most of them diagnoses around dementia, mild cognitive impairment as well, but able to sort of have a more in-depth conversation around what the risks would be from a frailty, from a delirium, from a functional maintenance perspective in terms of the perioperative, peri-transplant period of time, as well as the longer term horizon. Some of the additional data from our clinic. So waitlist time at this point is generally about 2 months. We did administer a patient satisfaction survey with these visits, and found that satisfaction was fairly high. And then we were able to complete a number of other interventions as well that I've just listed, which I haven't really captured in those broad categories, but I think is par for the course for geriatricians when you do a CGA and you end up identifying many more issues to address than the original reason for referral. So some of my early reflections in terms of this pilot clinic we have at St. Paul's, and with that geriatric nephrology lens, is that we really do see a good level of patient complexity and a wide range of issues to address in these visits. And I think we really have a unique advantage in having access to some of the allied health services that really already exist in renal, showing that really that bilateral communication and co-management of patients can go a really long way. I think we have some opportunity for more involvement with some of the other renal services and for participation even in some of the family meetings and renal rounds. And certainly I'd be interested to see how the rest of our pre-transplant patients do and what their outcomes are post-transplant, both in the short and long term. We did encounter some challenges that I think are not unique to this patient population. So, no-shows or patients who have limited sources of collateral or supports, One challenge, I think, with dialysis patients is sort of scheduling around a lot of their pre-existing visits and appointments. We were also asked to see a number of patients from other health authorities or rural communities, because often they come down here for their pre-transplant assessment. And then we are having to think about, okay, we've seen this patient once, how do they carry forward in their home communities and continue to manage these things with their local providers? So going forward, we're working on some ways that we can continue this service dedicated to providing geriatric care for renal patients. I think there are some really, really interesting opportunities for collaboration. So for example, I spent some time with Dr. Rebai, who is a physiatrist at GF Strong, and he works in Fraser as well as at UBC, but he has started over the past few years a lung prehabilitation and post-transplant rehabilitation program. And I think he's quite keen to look at pre and post kidney transplant in terms of rehabilitation, prehabilitation as well. And so I think that would be really interesting. As I've alluded earlier, I think there is a large burden of symptom management that we can try and do for renal patients. And so this may be a place to consider, collaborating with palliative care specialists in terms of providing that service to renal patients. And then just like with Toronto and with McMaster, one of the pipe dream items may be thinking about the educational value of such a clinic for trainees from different backgrounds and whether or not, it can be formalized into a curriculum as well. So I've presented, this clinic to both the geriatrics and nephrology groups and have had some really valuable feedback, but certainly if anybody else in the audience has any ideas or suggestions, I'd be open to them as well. I wanted to give my thanks to everyone here on this page. I've had the really good fortune of having excellent supervision and mentorship from Drs. Chase, Cook, Hill, a lot of support from the division heads, Dr. Spencer, Dr. Koo, Dr. Beaulieu, Dr. Levin, and my collaborators from Hamilton, as well as the clerical support staff at the Elder Care Clinic. So with that, I want to thank everyone for your attention, and I'm happy to answer questions or take any comments.
Any questions from the audience? Dr. Godor.
Thank you for your presentation. When do you guys kind of initiate, or what kind of events I don't have a mic.
I'll try.
I can hear you. I can hear you, Anthony.
Okay.
Would initiate a discussion about withdrawal of dialysis?
Yeah, that's a really good question. And actually, at VGH and the hemodialysis, that's actually a project in the works in terms of how you identify or trigger these processes. Often, the conversation to withdraw dialysis can come from many places. So number one is from the patient verbalizing, wishes. Although sometimes that can be difficult for patients to do, whether it's language barrier or, as we know, with many chronic disease patients, that increased capacity for suffering as time goes along. But patient verbalization is one way that can happen. Another way is that it can be initiated from the provider's standpoint. For example, if we're seeing intolerance to dialysis, whether it's from a hemodynamic standpoint, from a comorbidity standpoint, sometimes from a behavioral standpoint. For example, if they have dementia and they are now exhibiting responsive behaviors, needing, psychotropic medications, that would certainly be a trigger to have conversations around goals of care. The project at, VGH, we're looking at how can you build reflexic triggers So for example, if a patient has been admitted multiple times, if a nurse has a conversation with a patient, they can bring it forward, how a social worker can bring things forward. So, I think that's one area I would certainly be happy to look into in the future, but generally it's either driven by the patients or the providers in those contexts.
Any other questions? And if not, Dr. Hung, one of the issues that's come forward these days is looking at the participants in any study. So the diversity of participants is now a focus on ongoing studies, not just in nephrology or geriatrics, but in all of the studies that are. So is there I recognize that you're starting a clinic, but are there different populations that want different things? Is this a diverse population? Is it applicable to generalization in a Canadian sense, or in a, maybe you could give us your thoughts on that. So who are the participants, and does that influence at all some of the outcomes?
Yeah, so again, a lot of the data that I presented today is specific to this population of patients who are older, so over the age of 75, and often quite comorbid. So you're right, there's, when patients get older, there's really that spectrum of patients who are, healthy aging versus, frailty and all the associated syndromes. And so in the clinic, the patients that we've been seeing have been referred because there are some concerning features about how they are doing. So certainly, I think I'm capturing, if you can say this, sort of the frailest of the frail. And so, this is the perspective I have in terms of the patients that I'm seeing. And I think my data is going to reflect the patients that get referred to me. But I hope that, as we start to see more patients, we will also start to be able to identify maybe some of the patients who are more resilient and more physically robust, as the other study I pointed out has shown. And because I think that can be really helpful as well. So we don't swing fully from, we're going to dialyze everyone to we're not going to dialyze anyone, and have a little bit more granularity in that middle gray section.
But I guess in part I was referring to male, female, culture, ethnicity. Are you looking at those aspects, and does that influence some of the information that you're gathering, and as I say, the generalizability of your information to the population?
Oh yeah, thank you, Dr. Casson. That's a really, really important point. So the data I'm collecting so far, so I've only got the really rough categories. So I am collecting data in terms of their ethnic background, in terms of their gender, in terms of their marital status. So those are the few things that I've started to collect in terms of quantitative data. I think from a qualitative standpoint, I think that's a really important consideration. And, I think some thought has to be given in terms of maybe having more interviews, and how this type of assessment or care model might be helpful, or where it may improve for these patients. I do think you're right that, your culture and gender and social context does matter. But currently, as it stands, I'm just only collecting the very rough bits of data on this.
Good. Thanks, Wayne. Sorry, we're running out of time, and I just wanted to mention to the group before I thank Dr. Hung that if you're not tired of nephrology, please come back next week. Since next week it's Dr. Adira Levin, and she's going to be talking about kidneys and COVID. So thank you, Dr. Hung, for the presentation and for the new approach to end-stage renal disease that you've shared with us. Thank you very much.
Thank you, Dr. Casson. Thank you, everyone, for your participation. Take care.